Okay, let's talk about abdominal pain. It's one of the most common things you're going to see in primary care. And honestly, it can be one of the most stressful. The list of what it could be is massive. I mean, it ranges from something simple like trapped gas all the way to a life-threatening ruptured aneurysm. Your assessment skills are pretty much all that stands between a routine case and a total catastrophe. So in this explainer, we're going to build a systematic approach that's going to keep your patients safe and, just as importantly, give you the confidence to handle these situations. So picture this. This patient is sitting in your clinic room right now. He looks pale, he's sweating, he's clutching his stomach. Your mind is already racing, right? You're thinking through a whole list of potential disasters. This isn't just some textbook question. This is the reality of the job. Being able to think clearly when the pressure's on is absolutely key, and that's exactly why having a reliable framework isn't just helpful, it's essential. So here's our game plan. We'll start by defining what we mean by the acute abdomen challenge. Then, we're going to dive into the #1 priority, spotting the red flags. After that, we'll go through your clinical toolkit, history and examination, and then learn how to think by location. We'll zero in on those must-not-miss diagnoses, and finally, we'll pull it all together into a safe, actionable plan for primary care. Let's kick things off with the core concept, the acute abdomen. You'll hear this term a lot. It basically refers to any sudden severe abdominal pain. And while, yeah, most cases you see will probably turn out to be something benign, your primary job, your first responsibility, is to actively rule out the life-threatening stuff first. This isn't being a pessimist, it's just being a safe doctor. This right here, this is the single most important rule. For your exams, and definitely for your future practice, you have to actively look for and rule out the dangerous stuff before you can feel comfortable settling on a simple diagnosis. A classic trap for juniors is to jump to a conclusion like gastroenteritis without first stopping to think, could this be appendicitis or an ectopic pregnancy? You have to exclude the killers first. And that leads us perfectly into the most critical part of this whole assessment, spotting the red flags. These aren't just interesting clinical findings, they're giant stop signs. Recognizing them is a non-negotiable skill that tells you to stop investigating and start escalating immediately. So just take a second, think about it. Think back to that 68-year-old man. What signs or symptoms would make you pick up the phone to the emergency department right then and there? Let's walk through the checklist. Okay, if your patient has any of these, the game completely changes. Are they hemodynamically unstable? Low blood pressure or racing heart? That screams shock. Did the pain come on suddenly, like a thunderclap? That suggests something has burst or torn. Is their abdomen rigid with guarding? That's peritonism. It means the problem isn't contained anymore. Add in things like persistent vomiting or signs of bleeding, and the message is crystal clear. This is a surgical emergency. These aren't suggestions, they are commands to act. So, what happens if there are no immediate screaming red flags? Well, now you can take a breath and proceed with your full assessment. But you have to be systematic. A structured approach is your safety net. It makes sure you don't miss anything, and it's exactly what your examiners want to see in an OSCE. When you're taking a history, you'll obviously nail down the details of the pain itself, but you've got to broaden your questions. Ask about their medications. Are they on NSAIDs that could be hiding a perforation? And I cannot stress this enough, for every single female of childbearing age, you must ask about their last menstrual period. You have to explicitly consider the possibility of an ectopic pregnancy every single time. Now for the examination. Where do you start? Vitals. Always. Before you even lay a hand on the patient, their heart rate and blood pressure tell you objectively how sick they are. Only then do you move on to the abdominal exam. You're feeling for tenderness, for guarding, and then trying to elicit those specific signs, like Murphy's for cholecystitis or tenderness over McBurney's point for appendicitis. Okay, so you've got your history, you've done your exam, and you've got all this information. Now what do you do with it? The most effective way to start building your list of possible diagnoses is to think anatomically. The location of the pain is your biggest clue. It's like a map pointing you to the organs that might be in trouble. This little framework is an incredibly powerful mental shortcut. Pain in the right upper quadrant? Your brain should immediately jump to the liver and gallbladder. Epigastric pain? Sure, think stomach, think pancreas, but you absolutely cannot forget cardiac causes. A heart attack can present just like indigestion. And right lower quadrant pain in a young woman, that is appendicitis or an ectopic pregnancy until proven otherwise. Using this location-based approach is super high yield for exams. Now, while that table covers the common things, there's a special list of diagnoses that are so dangerous we have to give them their own section. These are the ones where a misdiagnosis can have absolutely catastrophic consequences for the patient. These are the big five, the diagnoses you just cannot afford to miss. They all present a little differently, but they share one terrifying feature. They all have the potential for a rapid, catastrophic decline. So let's quickly go through why each one demands such a high level of suspicion. First up, appendicitis. The classic story is a vage pain around the belly button that then moves down and localizes to the right lower quadrant. The real danger here is rupture. What starts as a contained infection can spill out, causing widespread peritonitis and leading to life-threatening sepsis. Any delay in diagnosis directly increases this risk. The clock is ticking.
Look, I know I'm sounding like a broken record, but it's for a very good reason. In any female of childbearing age with abdominal pain, you have to rule out an ectopic pregnancy. If it ruptures, it can cause a massive, concealed internal bleed. The patient can literally bleed to death inside their own abdomen in a matter of hours. This is an absolute can't-miss diagnosis.
And this is what we were so afraid of in our opening scenario. The classic picture is an older man with severe abdominal or back pain who suddenly becomes hypotensive. A ruptured AAA is one of the most lethal emergencies in all of medicine. The mortality rate is incredibly high, even if they make it to surgery. Next up is bowel obstruction. The key things to listen for are a swollen, distended abdomen, vomiting that might even start to smell like feces, and absolute constipation, meaning they're not even passing wind. The danger here is that the blocked-off section of bowel can lose its blood supply, leading to ischemia, tissue death, and perforation. Okay, so you've taken the history, you've done the exam, you've thought about your differentials. Now what? Your management plan from here is going to split down one of two very, very different paths. It all boils down to this simple split. If the patient is stable with no red flags, you can manage them in primary care. That means things like pain relief, really clear safety netting advice, and a plan for follow-up. But if any red flag is present, your role instantly flips. You are no longer an investigator. Your one and only job is to arrange an immediate, urgent transfer to the hospital. Do not delay that transfer to run tests in the community. Let's condense all of this down into a simple, repeatable algorithm you can use on the ward or in an exam. Step 1, check their vitals. Step 2, hunt for red flags. If you find any, step 3 is an urgent referral. End of story. If there are no red flags, you move to step 4, a full history and exam. Step 5, build your differential diagnosis. And step 6, manage the patient with clear safety netting advice. This simple process makes sure you never miss a critical step. All right, to finish up, let's hit some high-yield exam pearls. Vitals first, always. In a woman of childbearing age, always think ectopic. In an older patient with back and abdominal pain, always fear a leaking AAA. If you find signs of peritoneum, that's a surgical abdomen until a surgeon tells you otherwise. And finally, remember that safety netting, telling a patient to come back if it gets worse, is only safe after you've done a thorough and well-documented assessment. So let's end with this. The next time a patient with abdominal pain is sitting in front of you, before you even ask their name, the very first question that should pop into your head is this: is this patient sick or not sick? Answering that one question by actively looking for those red flags is the first and most important step every single time.